Good afternoon, everyone. Xin chào các bạn. It's a great pleasure to be here and to share a great important insight with you today. Today's topic is safe filler injection technique to prevent filler complication and protocol for filler vascular adverse events. Let's start with the introduction. My name is Yong Seong Choi. I'm Dr. Yong Seong Choi. I am founder of LC Plastic Clinic. LC stands for Lifting Choice. I'm graduate the Catholic University Medical School. I am board certified plastic surgeon. Tôi đã bắt đầu học tiếng Việt vào năm 2017. Tên tiếng Việt của tôi là Thằng Com. Tôi có kênh YouTube là Thằng Com TV. Tôi muốn giới thiệu và bấm mỉ nhiều phương pháp làm đẹp tại Hàn Quốc dành cho các bạn Việt Nam. I am also member of Smile for Children, participate volunteer for Create Palette and Lip Surgery in Vietnam, thành phố Vinh, ở Nghệ An. Có ai quê ở Nghệ An không? Tiếng Việt Nghệ An rất khó, các bạn đồng ý không? Okay, let's start today's topic. As you know, the global use of dermal filler has been rapidly increasing in recent years, and as the number of filler procedure grows. Unfortunately, we are also seeing a rising number of filler-related complications. To prevent this complication, it's essential to understand the safe injection protocol and to have a solid knowledge of facial anatomy. Complications after filler injection can occur anytime, and we generally divide them into early and delayed type. We can also classify them by severity, either minor or severe case. Let's look at how filler complications are classified. Early complications, which usually appear within a few hours to a few days after injection, include pain, swelling, bruising, and vascular occlusion. Delayed complications, which may occur weeks and even months later, including granuloma formation, migration, infection, and Tinder effect. Among these, vascular occlusion is one of the most serious complications. It can lead to significant tissue damage and long-term sequelae if not managed properly. Therefore, prevent and prompt treatment are absolutely critical. In today's presentation, I will discuss safe filler injection technique to prevent filler complication and the protocol for managing filler-related vascular adverse event. Here you can see a facial vascular model created by injecting latex into a cadaver. As you can tell, it's extremely difficult to complete a void vessel during filler injection because the human face contains an incredibly rich and complex vascular network. So question is, how can we safely inject filler into the face? Trời ơi. The answer lies in precise anatomical knowledge. If we truly understand the depth, distribution, and variation of facial vessels, we can perform filler injection much more safely and effectively. For this presentation, I referred to the following key resource: guideline for the management of hyaluronic acid filler-induced vascular occlusion, consensus opinion for the management of soft tissue filler-induced vision loss, and filler complication textbook written by Dr. Lee Won, next speaker from Lee Won Plastic Clinic. I would like to explain my sincere gratitude to Dr. Lee for his outstanding work and contribution to the field. All right, let's begin. Let's start with skin necrosis. One of the most feared complications after filler injection. Skin necrosis occurs when the pressure around the vessel increases, compressing the vessel and reducing or completely block blood flow to the skin. The closer the injected filler is to the skin surface, the higher the risk of necrosis becomes. This is because dermis is tight and compact layer, while the subcutaneous tissue is relatively loose, allowing for the better blood flow and low risk. Several factors increase the likelihood of skin necrosis: thicker skin, larger filler volume, use of smaller diameter needles, and injection in highly vascular area. These conditions all raise intradermal pressure and the chance of vascular compromise. Now, let's look at filler danger zones. When filler is injected venous thick skin, internal pressure rise. So we must be extremely cautious in this region. If we set the upper eyelid thick as 1, then areas such as the glabella, nasal tip, and chin have a relatively thicker skin, and thus a high risk zone. We should also take extra care when injected near isolated area around the vascular foramina and notches, because these are entry point for important arteries and veins. Vascular obstruction can be divided to two main types: extended necrosis, which occurs when large vascular plexus are affected, and localized caused by occlusion of a small vascular branch. Extended necrosis usually appear with branching redness and spreading pattern, whereas localized necrosis present a homogeneous redness, localized pattern. Here you can see an example of localized necrosis, a case confined to the nasal tip region. On the right side, a black escarp has already formed, indicating poor prognosis for tissue recovery. In contrast, extended necrosis can can spread widely. For example, in the left image, necrosis developed along the lateral nasal artery after nasolabial field injection. In the right image, necrosis spreading along the dorsal nasal artery following nasal filler injection. Both cases clearly shows branching redness and spreading pattern of necrosis. Other feature of extended necrosis is reactive hyperemia. As blood flow is blocked in one area, the surrounding vessel try to compensate by increasing blood flow. This leads to redness or flushing in front of the occlusion entry point. Vascular occlusion can further be divided based on whether artery or veins are affected. Arterial compression versus venous compression. Arterial compression typically present with libido mottling and sharp, intense pain. Capillary refill usually absent. And treatment requires high dose hyaluronic acid, one compression, and gel massage. On the other hand, venous compression shows a proper brush discoloration with the gradually, gradually, gradually worsening pain. In this case, capillary repair is delayed, and tissue change progress more slowly compared to arterial occlusion. Next, we will look at the five progressive stages of vascular occlusion, from early branching to tissue necrosis, and discuss how to recognize and treat each stage effectively. Now, let's move on the five progressive stages of vascular occlusion. Recognizing this stage is extremely important because each stage requires different treatment approaching and timing. The five stages are para, libido reticularis, post, for coagulation and devitalized tissue or eschar formation. Let's go through each one step by step. First, para. The first stage is para, or skin branching. This occurs immediately after filler injection when blood flow and tissue perfusion are suddenly reduced, usually due to arterial blockage. Para typically appears within seconds or minutes or injection. It's warning sign that filler might be obstructing an artery. At this stage, we can check capillary repair. If repair is slow or absent, it indicates arterial occlusion. Or repair is fast, it may suggest venous congestion instead. This is a critical moment to act quickly. Inject hyaluronic acid, apply warm compression, and gel massage right away. 2. Libido reticularis. The second stage is libido reticularis, a net-like redness or purplish discoloration of the skin. This pattern appears because of the enzyme structure of facial blood vessels. When a vascular territory is blocked, adjacent vessel starts showing this reticular pattern due to ischemia in the distal branch. During this stage, vasospasm may also occur, causing collapse of distal vessel and worsening ischemic change. Even if we inject hyaluronic acid and attempt decompression at this stage, slowing or eschar formation may still develop later. So, early intervention, ideal during the peril stage, is always the goal. 3. Post-formation, bacterial viral burden. The third stage involves post-formation due to bacterial overgrowth. As the sweet gland loses function, the skin pH drops, creating favorable environment for bacterial proliferation. Decompression is essential here. Otherwise, bacteria can spread deeper into the skin. Interestingly, some patients may still recover where if their degenerativity capacity is strong, but in most cases, from decompression and proper wound care are crucial. 4. Coagulation stage. The fourth stage is coagulation. Prolonged ischemia lead to cytokine release and platelet aggregation, which not only worsen vascular compression by forming microzombie, but also further reduce proportion around the filler particle. 5. Devitalized tissue eschar formation. Finally, the fifth stage is tissue devitalization, characterized by slowing and eschar formation. This is the result of prolonged ischemia leading to full thickness necrosis. Debridement may be required, but it's best to wait until demarcation. The clear boundary between viable and non-viable tissue is complete. Aggressive or early debridement is not recommended because new blood flow from the wound base is often still developing. In short, patient and gentle wound management are key in this stage. So to summarize this section, understanding which stage you are dealing with is critical to deciding when and how to intervene effectively. The earlier you recognize vascular compromise, the better the chance of saving the tissue and minimizing scarring. Okay, quiz time. Stage 1, 2, 3, 4, 5, and extended burst, localized necrosis, or arterial or venous compression. This patient filler injection lateral cheek area 2 days ago. 2 days later, this pattern appear. Which one answer my question? Stage, extended or necrosis, localized necrosis, arterial or venous compression. Anyone? Too thin? Okay. Transverse facial artery occlusion, arterial compression, extended necrosis, stage 2. Next case, lip filler injection. The patient had lip corner lift surgery 10 years ago. Immediate filler injection. Second photo is immediate filler injection. 1 day later, filler injection, libido reticularis appear, decompression. 1 day later, decompression, the symptom is release. 2 days later, decompression, 2 months later, no complication and recovery. Okay, next let's talk about how to manage suspected skin necrosis, specifically decompression technique and wound dressing strategy. So let's discuss what to do when you actually suspect skin necrosis after filler injection. The two most important principles are decompression and proper wound dressing. Among these, early decompression is absolutely critical. The early act, the better the clinic outcome will be. Decompression. If you notice branching immediately after injection, you must perform decompression right away, ideally within minutes. However, be careful to differentiate true ischemia branching from temporary branching caused by epinephrine in local anesthesia. Epinephrine branching resolves quickly, while ischemic branching persists and spreads. For decompression, mix 1 vial of hyaluronic diazide, 1,500 unit with 1 cc of normal saline and inject it directly into and around the affected area. Then gentle massage the lesion to help enzyme diffusion. This step helps break down the filler and restore microcirculation. Uh, Treatment protocol for filler vascular adverse event. Around 3 days, around 3 days after injects, pustules often begin to form. At this stage, sweat gland function has decreased, the skin pH has dropped, and bacteria can easily proliferate. Pustules usually appear when decompression was not performed early enough, or when vascular compression remain severe for 48 to 72 hours. Necrotic tissue rapidly lose moisture and become covered by a thick scab. Underneath the scab, pus can accumulate, destroying the subcutaneous layer and resulting in depressed scar, which is significant worsen cosmetic outcome. So it's very important to remove pustule, control bacterial overgrowth, and maintain a closed, moist wound environment to prevent desiccation and secondary infection. Dressing and wound care protocol, treatment protocol for filler vascular adverse event. During the first week after filler injection, the goal is maintain hydration and perfusion of the wound. Continue hyaluronidase injection up to 3 times a day if needed, and apply closed wet dressing to support tissue recovery. After 48 hours, once breathing or tissue breakdown begin, focus shift to infection prevent and optimal wound healing support. This includes debridement, oral antibiotics, and topical agent when necessary. In the second and third weeks, you can do the wet to dry dressing to prompt autolytic debridement, avoid aggressive surgical debridement at this stage. It can worsen tissue damage and delay the epithelialization. By third and fourth week, you can start PDRN or PN injection and perform toning or fractional laser treatment to prevent post-inflammatory hyperpigmentation (PIH) and support regeneration. Supportive therapy to improve blood flow. Aspirin can be administered. Initial dose of 300 milligram followed by 75 milligram daily for maintenance. If the patient is allergic to aspirin, clopidogrel is an alternative. One compression can help with vasodilation, and gel massage can help break down filler particle and relieve pressure. However, nitroglycerin paste and sildenafil and hyperbaric oxygen therapy are generally not recommended, as their benefit is limited and they may worsen inflammation and reperfusion injury. Likewise, steroids should be avoided in the early phase because they can delay the wound healing and increase infection risk. If vision loss occurs, which indicate retrograde arterial embolization to the ophthalmic artery, this becomes a true emergency. In such case, retrobulbar hyaluronic daze injection and immediately ophthalmologic management are absolutely necessary to prevent permanent blindness. So to summarize this section, when you suspect skin necrosis, act immediately with decompression using hyaluronic daze. Maintain most wounded environment to support healing. Avoid aggressive procedure until clear demarcation occurs. Control infection and support vascular recovery with medication and gentle care. This principle can make a huge difference in patient outcomes. Let's finish with prevention, especially the safe filler injection technique summarized by the ABCDEFGH protocol. ABC. Now let's talk about how we can prevent filler-related vascular complication. I will explain this with acronym ABCDEFGH. First, anatomy. Through understanding of facial anatomy is fundamentally. We must consider the depth, distribution, and common variation major vessel and always identify the safe injection plan. Particular caution is needed to around the supratrochlear artery, supraorbital artery, and dorsal nasal artery. The glabella, nose, and forehead are very high risk area. These three arteries branched from the internal carotid artery, which connect to the ophthalmic artery and thus can lead to the retinal artery occlusion if injected improperly. B is being needed using a large diameter needle or cannula is safer. Small needles can easily penetrate vessel walls, increasing the risk of intravascular filler injection. Therefore, a large gauge instrument is recommended to minimize the risk. C. Compression. When injecting the territory of the STA, SOA, DNA, you should compress the vessel password during injection. As shown in the anatomical reference image, this halves the chance of filler entering the vase. The direction. The injection direction should always to parallel to the artery, and ideally performed from proximal to distal. This approach reduces the risk of vascular penetration. E. Epinephrine aspiration. Epinephrine causes vasoconstriction, which may help prevent vascular compromise. Using lidocaine with epinephrine has additional advantage: less pain, less bleeding, and less swelling. Aspiration should always be performed before injecting, especially in areas with large vessels such as supratrochlear artery, supraorbital artery, and dorsal nasal arteries. F. Filler injection technique. There are two main techniques: single bolus injection and linear threading. Among these, single bolus inject technique is generally preferred. After punching, wait approximately 5 seconds before injecting to check for any bleeding, which helps identify intravascular placement. 3. Gentle. Inject slowly and with minimal pressure. High pressure increases the risk of vascular injury. To minimize injection pressure, use a large diameter needle with small volume syringe. H. History take. Always review the patient's operation history. Previous surgeries can alter normal vascular anatomy, increasing the risk of complication. Be especially cautious in patients with facial implants such as rhinoplasty, since the implant and its capsule in distort the natural vascular course. Summary, by following these 8 principles, A to H, we can significantly reduce the risk of vascular occlusion and other severe filler-related complications. Xin cảm ơn.